have recently had your large-scale randomised trial of EMR cap versus duet accepted for publication. Can you just summarise the results for us, perhaps?
Yes, that's going to be published in Gastrointestinal Endoscopy, and it's a randomised study in which 82 patients were randomised, 84 patients were randomised 42 versus 42 in MBM or EMR cap. We restricted the patients to Barrett's patients that had flat type lesions, in which we thought that piecemeal resection was required. Delineated the lesion, and after the lesion was delineated, only then randomized them to either MBM or EMR cap. Both techniques turned out to be very effective, but the duet turned out to be much quicker. The average time required for the resections, and median number was about 4 in each of the groups, was 34 minutes with the duet versus 50 with the EMR cap, which is quite understandable because you don't have to use submucosal lifting as you have to do with the EMR cap. You don't have to replace the snare as you have to do with the cap procedures. These very thin EMR cap snares are often very difficult to position in the ridge of the cap, and these two things take up much more time. The resected specimens were slightly smaller in the MBM versus the EMR cap group, 18 versus 20 millimeter if it comes to the largest diameter, and 15 versus 13 millimeters if it comes to the smallest diameter, which likely reflects the fact that with the cap you may get slightly bigger specimens, but the increase in size is fairly limited. And when we looked at how deep you resect, the depth of resection through the submucosal space, which decides how radical are you going to be, that was not significantly different between the two groups. So since we're doing a piecemeal resection anyway, we don't think that that slight decrease in size, in surface size of the duet for selected patients for piecemeal resection is that relevant. And it's the ease and the speed and the fact that much more endoscopists will find it much easier to use this technique than the EMR cap technique that, in my opinion, will make this the leading resection technique for piecemeal resection in the esophagus.
What about perforation risk for the respective techniques?
Well, in that randomized study I was mentioning, we actually had 4 perforations. That is much more than you would anticipate for normal resection. That was also partially because the last 50 cases were done by endoscopists that were part of a training program that we had, because we wanted to have an equal spread of endoscopic expertise. We had 3 perforations in the EMR cap group and only 1 in the MBM group. And the MBM case was actually quite an exceptional case of a patient that had an angel chick prosthesis inserted, and at the level with a lot of fibrosis then had a very small nodular lesion that was sucked in the cap with quite some resistance, and then ended up with a very concealed perforation. I'm not really sure how representative a complication like that is